64% more patients achieve that ACR 50, which is an astonishing number. So it turns out that, weight loss does help. DIP, distal interphalangeal joint involvement, very typical of psoriatic arthritis, this far joint of the fingers and toes. And I once had a room full of psoriasis. There were 107 psoriasis patients in the room. It was a talk I was giving at a patient meeting for the National Psoriasis Foundation. And I asked everyone to stand up.
Welcome to Derm-It Trotter. Don't swear about skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. On today's episode, we have Dr. Mark Lebwohl, board-certified dermatologist, professor and chairman emeritus of the Department of Dermatology at the Mount Sinai School of Medicine, and he is an expert and guru in all things psoriasis and somebody that I truly admire like most of my peers. Welcome to the podcast. It's so great to have you here.
Thanks for having me, Shannon.
Of course. And today we're going to dive into something with psoriasis that maybe some of our listeners don't know much about. And our goal is really to educate people on psoriatic arthritis. So I was going to have you kick us off, which is talking about, really what is psoriatic arthritis? And for our listeners out there that think, gosh, I have psoriasis, but nobody's talked to me about, joint pain or arthritis, what's the likelihood that I might develop it?
So if you have psoriasis, the chance of getting psoriatic arthritis is about 30%, almost 1 in 3. It's a fairly high number there.
And do you think, for those patients that have psoriatic arthritis, do you mind defining, what does that look like? What does that mean? And people might say, well, I have some joint pain or discomfort, but, is it really psoriatic arthritis? How does it typically present?
So, if you have psoriasis and you have joint pain, don't let your physician just treat your psoriasis. You have to say, I have joint pain, because the treatments are very different based on whether you have psoriatic arthritis, or even if we think you might get psoriatic arthritis, we are going to use different medications than if you just have skin disease. So really important to let your doctor know about those joint pains. And I will say there's a tremendous amount of data showing that if you treat psoriatic arthritis early, you'll do a lot better in the long run than if you treat it late. And there's literally every study that looks at that question shows that information.
So probably a lot of people out there might be ignoring some of those joint symptoms or attributing it, maybe they're just getting older, right? Or, it's just normal to have that. So in the context of psoriasis, your advice is definitely bring it up, because it might be psoriatic arthritis, or it could be another form of arthritis too.
Yes,
that
absolutely.
Needs potentially to be addressed. Or I guess you could have the double whammy, right? You could have an overlap. You might have psoriatic arthritis and maybe osteoarthritis combined with it, which I know could be challenging to manage. Probably a lot of the adults out there with psoriasis are thinking, okay, I've got an element of some joint discomfort, but what about children in psoriasis? Because I think people wonder, does this even happen to kids too? Or is it less likely, or does it present any differently? Or does it need to be on the radar of those parents out there whose children have psoriasis?
Yeah. So 2 points there, and I will address the children question right away. But some of our most complicated patients have psoriasis of the skin and probably a combination of osteoarthritis and psoriatic arthritis, which makes them a little bit more difficult to diagnose and also a little bit more difficult to manage. But many of our patients have both. And so that was a good point that you made. As far as kids, yes, kids can get psoriatic arthritis. I've seen children as young as the age of 2 with psoriatic arthritis. And as kids get older, the kind of signs and symptoms they get are very similar to what we find in adults. But in young kids, a couple of things are noteworthy. In general, we say that psoriasis precedes arthritis or occurs at the same time, 85% of the time. In children, so that means only 15% does the arthritis precede the psoriasis. 80% of kids with psoriatic arthritis will get skin disease. And so the numbers are much higher there. The association's much stronger. There are also some different associations. They're more likely to get uveitis, for example. So we're We treat kids with psoriatic arthritis quite specially. Fortunately, more and more drugs are now approved to treat psoriasis in children, uh, and uh, uh, and and since many of those kids will develop psoriatic arthritis, we do have tools we can use that are very effective in those children.
So now that we've kind of tackled, just sort of what is it a little bit, a lot of people might be wondering, like, what is this connection, between the immune system, our skin, our joints, why does this actually happen? Going into maybe like the science of it, or a little bit of the immune system for our audience to understand.
Mhm.
And, do we know why some people are lucky enough not to do it?
Sorry about that.
Oh,
Uh,
you're
the the answer is that both psoriasis and psoriatic arthritis are what we call multifactorial, meaning you inherit a combination of genes from both parents, and combined with external factors, it gives you the disease. So, for example, you may have one parent with psoriasis. The chance of a kid getting psoriasis might be 1 out of 6. But you take that same child and you move them close to the equator, it'll be lower. You move them
Mhm.
to northern latitude, it'll be higher. So it's a combination with external factors. If both parents have psoriasis, the chance of a child getting is probably about 1 in 2. So it's a combination of genes from both parents combined with external factors. The same for psoriatic arthritis. The chemicals that we associate with psoriasis are often the same as those associated with psoriatic arthritis. For example, TNF alpha, IL 17 are both chemicals that we see in both diseases, and blocking both of those chemicals are highly effective in improving psoriasis and in improving psoriatic arthritis.
You mentioned some of those external factors. What kind of external factors do you kind of think of in regards to that as well?
So I would say, sunlight is a major factor.
Hmm.
Obesity, it turns out, is quite a factor. And, just a few weeks ago, there was a press release and a publication about an article in patients treated with ixekizumab and tirzepatide, which is a weight
Hmm.
loss drug. And the results were off the charts. There's a tool we use to measure the severity of psoriatic arthritis called the ACR 50. And when you combine the weight loss drug with the biologic for psoriasis, 64% more patients achieve that ACR 50, which is an astonishing number. So it turns out that, weight loss does help. And we'll talk about diet a little bit later when you ask me about myths in psoriasis. But I would say there's no particular food; it's being overweight. And we
Hmm.
know actually that people who are obese, that that extra fat that they get secretes some of the chemicals I just mentioned, like IL 17 and TNF alpha. And that's why both psoriasis and psoriatic arthritis are made worse by being obese.
Yeah, I think it's fascinating how we think of, our fat or adipose tissues sort of being just quiet and stagnant. People have this misconception, but it's pretty active metabolically and kind of
Mhm.
fueling things in the body, and learning so much more about it, and its role for psoriasis is fascinating. Now a new target for treatment, which we'll talk a little bit more about. But I also want to touch upon, people are sitting there thinking, do I have psoriatic arthritis? We talked about joint pain, but I wanted to go into more about how it may present, maybe where there's certain areas of skin involvement for psoriasis, or obviously nails, or things that might put you at risk that we know clinically, or, how do these joints actually look, or what areas tend to be affected for
Yeah.
somebody that might have psoriatic arthritis?
So there are multiple forms of psoriatic arthritis. The most common is called oligoarticular. Oligo means a few joints. So you might have, one or two or three joints affected. Um, the polyarticular is the other word that's used for that. Then there's a symmetrical arthritis that is very similar to rheumatoid arthritis, often involves the fingers and toes. But the patients have a negative rheumatoid factor, unlike rheumatoid arthritis, and they have psoriasis, unlike rheumatoid arthritis. So it can be distinguished from rheumatoid arthritis, but those patients get deformities that are identical to what we see in rheumatoid arthritis. So there's some old characteristic deformities called ulnar deviation or fibular deviation, where the fingers and toes turn outward. Um, There's something called a swan neck deformity, which I'm having trouble doing there. But the far joint bends forward and is stuck that way. There's something called the boutonniere's deformity, which looks something like this. Uh, and, um, and those are typically seen in rheumatoid arthritis. We see them in psoriatic arthritis as well. Um, uh, and there are other manifestations too. There's characteristic DIP, distal interphalangeal joint involvement, very typical of psoriatic arthritis. This far joint of the fingers and toes. We see something called Heberden's nodes, which doesn't hurt as much, are little like knobs on the DIP joints. That's an osteoarthritis. So, it helps to be able to distinguish those. Um, uh, there's ankylosing spondylitis, which is basically psoriasis of the spine. Those patients also get sacroiliitis, inflammation of the sacroiliac joint. Um, there's a number of and then there's arthritis mutilans, the worst form, where
Mhm.
literally the joints are completely destroyed. And those patients, we fortunately hardly ever see that anymore because the
Mhm.
treatments have gotten so much better. But literally, the bones are eaten away, and those patients come in with completely deformed hands and feet. Difficult to use their hands, difficult to walk. Fortunately, that's a form of arthritis we don't see very often anymore. So there are
And
some pretty specific findings, and you may have alluded to that. Pitting of the nails is
mhm.
very common in psoriatic arthritis. Other nail changes are common in psoriatic arthritis. There's a condition called enthesitis. It's tenderness and swelling of the tissues around the joint. Can be very painful, and that's very characteristic of psoriatic arthritis. In fact, when I see an entire digit that's swollen, which is because of enthesitis, uh, that we call that dactylitis. Um, uh, I always assume that is psoriatic arthritis, even if the patient doesn't have psoriasis. And I can tell you my success rate with treating that with usually IL-17 blockers has been 100%. I find that they work really well for this very painful form of arthritis. And it really reverts it completely in every patient I've treated with dactylitis.
You mentioned kind of a couple interesting things there. One, where you just commented, that somebody may not have skin involvement but could have psoriatic arthritis. Is that a common presentation, or do you feel skin involvement eventually comes with it, or is that something you don't see very often?
So there's certainly a small proportion of patients who, by the way, have responded to the typical psoriatic arthritis drugs who have not gone on to develop psoriasis. Now, maybe it's because we've kept them on the psoriatic arthritis drugs.
Hmm.
But normally, usually within 8 to 10 years, the patient's going to have psoriasis of the skin. And by the way, in patients with psoriasis of the skin, it's about 8 to 10 years before that 30% develop psoriatic arthritis.
And so for the diagnosis part, probably like you're wondering, okay, I think I could have some signs and symptoms. My dermatologist might think I'm there, might make the diagnosis. Maybe they go to rheumatology. How is that diagnosis actually made? Like, are there particular x-rays, lab work? Is it more of a process of exclusion or criteria based? How does that diagnosis actually happen?
So, in truth, it's often seeing a patient and how they present to you, what their history is, that helps you make your way to the diagnosis. And sometimes, when we're not sure, we use the drugs that are specific for psoriatic arthritis, and that tells us whether or not the disease is there. However, there are criteria that we use, and there's one called the Caspar criteria, and it's a point system where you are given points for whether you have psoriasis and other features. So if you have psoriasis at the time of presentation, you get 2 points. If you have a history of psoriasis or a family history of psoriasis, you get 1 point. If you have abnormal nails like nail pinning or onycholysis, you get 1 point. If you have a negative rheumatoid factor, you get 1 point. If you have swelling of an entire digit, you get 1 point. And to me, again, that is almost always psoriatic arthritis. And then if you have on x-ray evidence of new bone formation next to a joint, that is also worth 1 point. And the bottom line is if you get enough points, you have a diagnosis of of psoriatic arthritis. There's a tool that's used in clinical trials more than anything else. I actually printed it up, and I don't use this in the office, but we use it in clinical trials to see if patients might have psoriatic arthritis. If you have 3 points out of these 5 yes/no questions, it is presumed that you have psoriatic arthritis. And this is just a kind of screening tool that helps you a little bit. It's not 100% sensitive, not 100% specific, but it's fairly sensitive and specific. So, have you ever had a swollen joint or joints? Has a doctor ever told you have arthritis? Do you have finger or toenail holes or pits? Do you have pain in your heel? Another fairly specific finding for psoriatic arthritis. And have you had a finger or toe that was completely swollen and painful for no apparent reason? Again, that's dactylitis, and that is again a much more specific question. If you answer the last question correctly, there's a high likelihood, in my opinion, of psoriatic arthritis. That tool is called the PEST questionnaire, and we do use it in clinical trials.
And I mean, I have to say too, it's a great questionnaire, even in everyday practice, pretty straightforward and easy to do. Or even I think if patients start thinking
Yeah,
about that, to really help, define what's going on maybe and, suggest if yes, they could
yeah,
potentially have psoriatic arthritis. Because
yeah,
I think after people are diagnosed, we've touched upon this a little bit, the real question is, well, gosh, like, what are the treatment options? And I know we could spend a whole podcast and just going
yeah.
through each of them individually, but I was hoping to give like an overview, maybe traditionally what we looked at and of course where we've come today.
So there are many drugs that are approved for psoriatic arthritis, um, but there are some that are clearly better than others. So we do, when patients have mild disease, use NSAIDs just like any other form of arthritis. So and the same NSAIDs, like I use a lot of enteric-coated naproxen. Uh,
Hmm.
uh, and there are other favorites that other rheumatologists and dermatologists have. But the bottom line is, with limited disease, you can easily control it, usually with pretty non-aggressive therapies. If that doesn't work, then uh, our next step would likely be an oral or a biologic therapies. I would say that many rheumatologists go right to methotrexate. The reason that I don't is it is much less effective than biologics and much more dangerous. The thing is, it's easy to get, it's cheap. And that's why rheumatologists go to it. And their guidelines even used to call for it as being the first line treatment. I hardly ever use it anymore. There's honestly a real death rate associated with methotrexate. And I just, don't want to always constantly be worried about my patient mixing another drug with it or getting into trouble because of their liver or bone marrow. Um, the go-to drugs have been more recently uh, either TNF blockers. The names of those are. Am I allowed to use brand names in this
Yeah,
podcast? Yep.
definitely do. Hmm.
Yeah, so it's Enbrel, Humira are very effective. Cimzia is very effective. There's something called Symphony, which rheumatologists use more than dermatologists, but it's very effective, and I've prescribed it. And Remicade, which is an intravenous form, probably the one with more side effects, but also very good efficacy. Um, those are used to be first line. Now more often, I first line go to an IL-17 blocker. The drugs that are approved are Taltz, Cosentyx. Siliq is not approved in the US, but it is approved in Japan and highly effective. And Bimzelx is the most recent one, and works a little bit differently than the other IL-17 blockers because it blocks IL-17A and F. So certainly in psoriasis, it shows greater efficacy and at least comparable efficacy in psoriatic arthritis. There is some evidence recently that um, an IL-23 blocker called Tremfya doesn't just treat psoriatic arthritis, but also prevents the X-ray progression of joint disease. The TNF blockers and the IL-17 blockers have been long known to do that. Now the evidence is that if you use Tremfya, your patient, it may actually also slow down the development of joint changes on X-ray. Of the 23 blockers, that has emerged probably as the most commonly used one. Having said that, there is data that Skyrizi and Ilumya, which are other 23 blockers, also work for psoriatic arthritis. Okay. The last drug we didn't talk about, actually, the two is Sotyktu and Otezla are approved for psoriatic arthritis. So is Stelara, but they don't work quite as well as the 17 and 23 block. I'm sorry, the 17 blockers and the TNF blockers.
So with all those treatment options out there, you mentioned you might start with an IL-17 blocker.
Often.
When you is it based on kind of your look at the data? Because I'm sure there's patients out there like, gosh, like, well, which one are they going to put me on? I know that sometimes there's other reasons to choose that class or not, but I wanted to get your thoughts specifically on psoriatic arthritis. Is that a lean that you maybe have? Are there other factors that you take into account as well?
I have a talk that I give which drug for which patient, and
Hmm.
I once had a room full of psoriasis. There were 107 psoriasis patients in the room. It was a talk I was giving at a patient meeting for the National Psoriasis Foundation, and I asked everyone to stand up, and then I said, I'm going to read a list of factors that affect your psoriasis and your psoriatic arthritis. I don't want you to do anything while I read the list, but listen. And if I mention a condition that affects you at the end of my list, reading that list, I want you to sit down. And it included things like history of cancer. Do you have heart disease, risk factors for heart disease, diabetes, hypertension, a history of heart attack, family history of heart disease, cigarette smoking, um, uh, multiple sclerosis, inflammatory bowel disease, a long list of conditions. At the end of that, I said, okay, if I said something you read, obesity is on the list too, by the way, I should mention. And if I said something that affects you, sit down. Out of 107 people, 106 sat down. And I
Wow.
think the 107th couldn't hear. Um, but it was quite eye opening.
Hmm.
And this it was based on an article that I published in 2019. We're actually publishing that now that there are all these new drugs added. The next iteration of that, I'm reviewing the final manuscripts now, are going to be a CME article in JAD, in the Journal of the American Academy of Dermatology, in the next few months, because there are many things to consider, which tells you which drug is best. Um, the Another factor is, to be honest, access.
Hmm.
If we're able to more easily get the drug because of your insurer, that will have some impact. Although in many states there's step therapy legislation, so if we think one drug is better than another, we're going to push for that drug. Um, the other thing that I look at very early on is obesity. If a patient is overweight, there's a very high chance that they will be leaving my office with a prescription for a weight loss drug. And I have over 100 patients now on tirzepatide,
Hmm.
which we have a lot of experience with. And we've shown that the combination of tirzepatide with, um, ixekizumab again, is good for psoriatic arthritis. Well, it's also good for psoriasis. Uh,
Hmm.
Again, I can only say what's in the press release because the article's not published yet. Uh,
Hmm.
well, it's almost published. But the bottom line is, when we look at PASI 100, which means 100% of psoriasis clearing,
Hmm.
it was 40% more likely if you were
Oh.
on the weight loss drug plus Taltz,
Hmm.
Zepbound plus Taltz, as opposed to Taltz alone.
Fascinating. So that kind of leads, we talk about the obesity connection, the improvement you've seen. What about diet? Do you feel like diet and exercise as effective, or do you feel like that's something that's a part of the complete treatment regimen to recommend to your patients as well, in addition to the other therapies?
Yeah. So first of all, exercise is very important. And by the way, one of the signs of this is morning stiffness. So if you sit idle for a long time and then you have difficulty getting up because your feet hurt, or you're holding onto a steering wheel for an hour and then you have difficulty using your fingers for, for a time, moving them lubricates them. And so, and if that lasts for 30 minutes, you have to walk around for 30 minutes before the pain in your feet goes away. That's psoriatic arthritis that needs to be treated. And so I will say, among the signs that we spoke about earlier, morning stiffness is one I didn't mention and is a very important one. Now, it also happens in the morning when people wake up. Suddenly their feet hurt. They can't.
Hmm.
Whereas when they went to sleep, they were fine. It's a little bit different than osteoarthritis, where wear and tear, using it makes it worse. Here, wear and tear makes it better. Um, I shouldn't say wear and tear makes it better, but basically, as you start using it, it feels better.
Hmm.
Okay, now, diet, there is no specific food that makes psoriatic arthritis better, but weight loss dramatically does. And weight loss is very important, and that's why Zepbound had those great results that you heard about.
And then I think too, people are probably wondering, well, I don't know that I have psoriatic arthritis. And you talked about treatment. Some of the treatments they might be on are also approved for psoriatic arthritis that they happen to be taking for their skin psoriasis. Is there evidence to suggest that if we start somebody on one of those medications, it may prevent or delay the onset of getting psoriatic arthritis? Do we have any data behind that, or is it more conjecture or kind of, just our guess that it might help with that?
There's some data and some registry information where large number of patients are followed for a long period of time. In terms of the data that has been published a lot comes from electronic medical records. I have to say, I believe the data, but it is extremely flawed. There's data showing that if you're on an IL-23 blocker, you're actually less likely to develop psoriatic arthritis than on an IL-17 blocker.
Hmm.
And the reason for that, and the authors even acknowledge it, it's something called protopathic bias. But what that means in English is if a patient comes to me and they have a little bit of joint pain and I'm not sure, I'm going to probably pick an IL-17 blocker. So when I turn around in 5 years, the chance of that patient going on to develop real psoriatic arthritis is increased because they probably had it when they started. Whereas if a patient has no joint pain, I might be more likely to use an IL-23 blocker. And so you look 5 years at those patients and they're fine. And so there are data that are published suggesting that IL-23 are better, but that's because of that bias. The best data is when you follow a patient prospectively, meaning you treat them, you see do they develop psoriatic arthritis, and that data was just presented with bimekizumab, Bimzelx, and they showed that over a period of years. And I was presented at the AAD meeting that just passed, and I saw the presentation. I don't remember the data exactly, but if I'm not mistaken, over 5 years, a group of psoriasis patients who were followed regularly, only 2% in 5 years progressed to psoriatic arthritis. That is much lower than what you would expect. And so it's pretty good evidence that IL-17 blockers do indeed prevent the development of psoriatic arthritis. And I do think both sets of drugs are good at that for the following reason. When I started training and we didn't have these drugs and all we had was methotrexate, we would commonly see patients with these deformed hands that they couldn't use and their deformed feet that were difficult to walk on. We hardly ever see that anymore because the drugs we have today are so much better. And when a patient comes, and psoriatic arthritis is really painful, those are the patients who are going to be treated with the right drugs. So we hardly ever see that anymore.
Gosh, I mean, it's amazing kind of like where we've come, with treatments, but there's still a lot of myths out there, I think, with psoriatic arthritis. So I want to give you an opportunity in the last couple of minutes to kind of bust some of those, or any advice, obviously, you have for the derms out there listening on how we manage our patients better.
Sure, eat all the gluten you want, but lose weight. I can't
I
tell
love
you how many patients come to me on gluten-free diets, and it's a waste of time. I mean,
that.
you either have celiac disease or you don't, and that's easy to prove. There are blood tests that suggest it, and their gastroenterologists have procedures where they definitively make the diagnosis. So when people ask me about diets, they're such believers. I'll just say, well, if it makes you feel better, have it. If it makes you feel worse, don't have it. And I'm kind of loose that way. But in my mind, I'm thinking, you know what, the diet has nothing to do with it. The weight loss, on the other hand, has a lot to do with it. And losing weight is really good for you. And exercising, don't stop exercising because of psoriatic arthritis. That is really bad for you.
It's going back to the old things that we know that work, no matter
Right.
what. I always have to say it always circles back. That's just the way life is, I think.
Yep.
Well, thank you so much for coming on the podcast. It's been great to have you on the podcast today, Dr. Lebwohl, and sharing your expertise. I know you've probably educated a lot of people out there, not only providers, but our listeners, because psoriatic arthritis is something we need more recognition for and really highlighting it.
Yeah, agree. Thank you very much for having me, Shannon.
Of course. And stay tuned for the next episode of Derm-It Trotter. Don't swear about skincare.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.